Okay, thanks very much. Thanks very much, Dr. Seong, for that comprehensive survey of sexually transmitted infections in people with HIV. There's a lot to talk about, and I see that we do have a number of questions from the audience. I'm going to prioritise those, and I might start with this final one that's just come up. Nice presentation from Mr. Wong. I think we'll call you Dr. Wong. And this person would like to ask about syphilis prophylaxis. Is there any, this is an interesting question actually, is there any prophylaxis for syphilis, and what kind of regimen, and what would be the considerations around prescribing someone prophylaxis for syphilis?
So I think there is some, thanks for the question and thanks for the introduction, Mark. I think there is, there have been some studies and there is some data around the use of doxycycline, for example, for syphilis prophylaxis. And I think in both the pre-exposure as well as the post-exposure kind of setting. To my knowledge, at least this data hasn't really been translated into widespread programmatic and clinical use for a number of reasons. I think certainly, I mean, there are sort of personal, not individual health reasons, such as, really looking at the use of doxycycline, which is, has been used historically for a long time, and our experience with doxycycline is fairly extensive. But definitely, in terms of the side effects and the toxicities of doxycycline, have to be considered and weighed against the use for prophylaxis. I think the other is, of course, the public health reason for it, given that doxycycline is unfortunately not specific enough only to syphilis, but also to a host of other bacterial STIs as well. And the concern where we have a large and a growing problem of resistance, not only to syphilis, but also to other bacterial STIs like gonorrhea and chlamydia, for example. So we could be kind of causing more problems than trying to solve. I don't think that it's definitely a no-go for syphilis pre or post-exposure prophylaxis, but I think more data is needed. I think more study in this area is required before we can make justified and reasonable recommendations.
Yeah, sure. Maybe just a follow up from me on that. Chen, is that right?
Chen Seong is fine.
Chen Seong, yes. That's right. Because Wong is your surname.
Yes, course. Wong is my family name. Yes.
I mean, would it maybe be? I can't remember. I think it was Jean-Michel Molina in France who first studied it. It was pre-exposure prophylaxis, and it worked quite well, right? I mean, in terms of efficacy, I think it reduced the incidence of syphilis by about 50%.
Yep.
And there were some side effects, but I think he did. I think in order to try and reduce the exposure, because there's concerns about other bacteria, selecting out resistant bacteria in the gut microbiome, for instance, that would be problematic, and by giving it just intermittently on demand, they were trying to reduce the exposure. But do you think maybe it needs to be studied rather than as a blanket approach in people that continue to present with syphilis, maybe 4 or 5 times a year? Would you maybe reserve it for people like that continue to get reinfected?
Yeah, I think so. And one of the things that we found, which I didn't present in my slides, but which I found in the study that I presented at our center, was that the risk of syphilis acquisition and reacquisition isn't standard throughout the entire cohort, right? I mean, and I think it's kind of stating the obvious. Certain people get infected more frequently, reinfected more frequently, and I think maybe taking a more a focused look at who might best benefit from taking doxycycline as pre-exposure prophylaxis would definitely be of use. And I think seeing whether that has the same, it comes with the same concerns that we have in Molina's study. I think that would be one approach, definitely.
Yeah. I mean, the other issue that he didn't address, and it's one we're trying to address in Australia with the cohort study at the moment, is the effects on the gut microbiome and degrees to which you might be selecting out other bacteria that are just bystanders. As you say, it's not exactly a targeted therapy, doxycycline. It's got broad antibacterial activity.
Yep.
And that may be something that puts people off. But we'll see what the data shows on that.
Yeah.
Now, Tim, I don't want to, I'm going to try and do questions person by person because I don't want you to feel left out. So we do have a question. Someone mentioned that CROI, presumably earlier this year, there was a study with bictegravir containing ART in which people were given the 1 month daily isoniazid and rifampicin treatment for latent tuberculosis. And it showed, or it suggested that there was an increasing risk with that combination of viral blips for HIV, presumably, I'm not sure what level, but presumably over 50. If it was combined with the, sorry, let me read the question exactly. In CROI, we saw a study on bictegravir and 1 month isoniazid rifampicin leading to increased risk on viral blips. Do you think that would happen if it was combined with the 3 month isoniazid rifampicin latent TB strategy?
Okay, well, it's always a tough question to make predictions, but I think if I recall the CROI presentation, but I think it's hard to remember with these virtual presentations these days. But I think it was done in Taiwan, and I think they showed that the levels of bictegravir were quite significantly lower, and some blips. And again, please correct me in the chat if I'm wrong. I think it was somewhere between 50 and maybe 200 or 400 copies. So they weren't full viral rebound. You're just having these blips.
Yeah.
So. And that's indication, the levels were lower, you're seeing these blips, and it was only over a month. So if you're thinking of, spreading this out, yes, to the 3 months, these blips might be more of maybe a clinical issue, especially as we've seen, if you just take the examples of with dolutegravir and rifampicin, where we saw with, the standard treatment, bictegravir, didn't overcome the double dose, but while with 3-HB and dolutegravir, the levels were actually quite low. So I personally think that, rifabutin is probably going to have a bigger effect actually on bictegravir than dolutegravir. So I would be, again, the study should be done, but I think I would be concerned looking at the 1-HP data that, giving this for 3 months now, where there may be more, the chance of selectivity because of these low levels is going to be maybe more clinical significant. Maybe they got away with it with the 1 month, because you have these blips, but 3 months is starting to be a bit of a concern as we expect it to be lower.
Sure. I mean, having said that, a lot of people have always worried about blips, and they've studied them intensively to see if they lead to, clear virological failure. And very few of them, I don't think any of them that have been done well, clearly show that increased blips lead to failure. But I think in that study,
you're right. In that study, I think as soon as they went suppressed, soon as they stopped.
Yeah. So blips worry people, but when people follow them up, it's pretty rare to see people failing. Nevertheless, obviously, it gives people concern. And I mean, the other issue about bictegravir, and you mentioned it, was that even if you double the dose in the presence of rifampicin, I think it was, you don't get back to a level that would be considered adequate. So, I mean, I take it from that point of view, and you mentioned that dolutegravir is likely to be more used in Thailand. I always know the problem with these middle-income countries that don't qualify for, the TLD type low-income country, the special price, right? They're sort of asked for much more like a commercial price, and therefore it's much harder. But presuming they do eventually come online, it seems to me that dolutegravir would probably be the best choice in order to cover those sorts of populations, particularly in countries where there's high HIV prevalence. Would you agree?
Yeah, I agree. I think, as you know Thailand very well. I think still dolutegravir is not actually available today within the national program, but hopefully soon. It's been earmarked for perhaps a year or so, but just to get from through the committees into the national program takes a little bit of time, but hopefully soon. But it does seem theoretically possible to get this over, but if some countries only have the fixed dose combination, they still need to have that extra 50 milligram tablet available as well. So that needs to be to double the dose. So again, when the countries are procuring these fixed dose combinations, they have to think about perhaps, obviously they do this situation, but having both formulations available is ideal for those settings with high TB like South Africa and India.
Yeah, sure. Yeah, it's such a common, it's probably the most common, complication, isn't it? HIV-related complication of HIV in those countries. Thank you. Back to you, Chen Seong. And this is always a question that comes up. I know when we have people with syphilis who are HIV positive, what's your recommendation about the performance of lumbar puncture for people with HIV and syphilis co-infection?
So I think the US CDC guidelines are fairly, they are in the process of being updated, but the US CDC guidelines are fairly unambiguous about it, where they generally recommend that anyone with syphilis and HIV co-infection have a lumbar puncture done for CSF analysis. In the real world, of course, it's a little bit more challenging. And I think if we look at what some of the risk factors are for actually having neurosyphilis, we know that the lower the CD4 count is and the higher the RPR titer is, for example, the more likely people are to have neurosyphilis. And of course, anyone with neurologic manifestations or a failure of the RPR titer or whichever non-treponemal test titer that you're using to for diagnosis and monitoring of treatment, if there's a failure of an adequate response, right? So at the bare minimum, a fourfold decrease after 12 to 24 months of treatment, then really we should be thinking about doing a lumbar puncture for to look for neurosyphilis. And those are the guidelines that we use in my center. We offer everyone who's been diagnosed with infectious syphilis a lumbar puncture, but we how should I put it? We offer it a little bit more vigorously in people who meet these criteria. So CD4 count criteria, RPR criteria, or of course, anybody who presents with a neurologic manifestation.
Yeah. I mean, I think clearly if someone's got a neurological problem, they really must have one, right? But practically, if there's nothing, I guess many times, I think probably in the real world, people just get treated and then followed up, right?
Yep.
Can I ask you another question from the audience? You mentioned about people who have, say, up to 6 or more episodes of herpes simplex that you might offer them prophylaxis.
Yep.
Can you talk a little bit about how long you would you treat that? How long before you might stop, and also what the dose should be?
For suppressive therapy, you mean? So I think, so the indications for suppressive therapy, we talked about just now, really looking at people who've got multiple episodes. There isn't really a sort of a recommendation for when to stop it. Obviously, if people are getting frequent flares, especially at a time when they are relatively immunosuppressed, if we do get good viral suppression and immune reconstitution, there's always a possibility of sort of scaling back or stopping HSV suppressive therapy and seeing what the frequency of flares are and whether there is any recrudescence. And if there isn't, we can continue to monitor clinically. But decisions around or making that decision with the patient to start suppressive therapy may be completely independent of what the patient's initial CD4 count is. You may get a person who's got fairly frequent flares, even with preserved. And to my knowledge, I don't think there is a clear recommendation or guideline on when we can stop immunosuppression. I think, chronic suppressive therapy. I think at such a point when suppressive therapy either becomes too onerous or we start to get complications from the use of acyclovir or valacyclovir, then there is a role for us to think about stopping it and seeing where we go.
Yeah, it's very interesting. I've been reading recently about people now saying with Hep B, this is completely irrelevant in a way, but we used to think if you treat it for life, but people are now saying, well, maybe we treat for 2 or 3 years and stop, and maybe up to 50% of people will remain suppressed. So this notion of stopping, prophylaxis, I think is topical and important, particularly in places where people have to pay for the treatment, right? It's
definitely.
One question for you, Tim. Did I hear right? But you said that with the efavirenz 400 dose, in the presence of rifampicin-containing anti-TB therapy, it doesn't have much effect on the PK profile, and there's no need to increase the dose back up to, say, 600, which everyone accepts is adequate?
Yes, I think, in Asia, there was a lot of, big study to show that the 400 milligrams efavirenz was non-inferior to the 600 milligrams, and in terms of toxicity and safe virological efficacy. So
it was worldwide. The Encore study was in 5 continents. It was Asia, Latin America, Africa. It was quite convincing.
So this applicable is 400 mil. I think that there is a fixed dose combination of 400 now.
There is.
So again, so this was the next question is always, well, what about TB? And so they did that study. It's quite a small study. But again, it's encouraging that, at least the concentrations, we always, as a pharmacologist, I'm interested in conversation, but we don't forget, obviously, the virological response. So I think that, the levels look, obviously they were lower, but, again, still close to that, boundary. And this is not a black and white boundary, really. I mean, so I think if we take that into account, I think, yes. And I think there's more evidence now that the 400 is, an appropriate dose for the, during the TB treatment.
It's interesting because I started that ENCORE study, about 10 years ago when we first looked for funding for it. And one of the first questions was, well, should we try efavirenz at 200? Because in fact, in the phase 2 studies, the 200 did just as well as the 400 and the 600. In fact, it did a little bit better numerically. But I think at the time, everyone thought that was just a bit of a bridge too far by taking the dose down, twofold, threefold or whatever. So, but it's sort of, it suggests that maybe 200 was enough, Anyway, that's a question that we'll never probably answer. And as we move on to probably better and less toxic drugs. I guess just following on from your idea of, this notion there's no black and white about pharmacology. Often, some people get away with sort of fairly low levels and some people don't. You showed that graph with TAF and then TAF with rifampicin, I think, and then you showed that the TDF actually achieved levels lower. But did you say that at the moment it's considered that TAF shouldn't be used in the presence of rifampicin containing anti-TB treatment?
I mean, that's per regulatory, package insert. But it is interesting that the intracellular levels themselves are still well above that you would get with a standard dose of TDF. So, and people have looked in, actually, I think if I remember right, maybe, maybe giving it once, I can't remember. I think there's some other studies looking into it, in slightly different regimens, but I think, they're being very conservative when it comes to the regulatory approval. So they didn't want to, rock that boat. So, but I think there should be some studies done. And if you look at the intracellular levels, and actually in that 1HP that was mentioned earlier with bictegravir, I think they were, perhaps they should measure also the TAF levels in that study to see how actually low they were in addition to the bictegravir. So it's a pharmacological, question. Is it, okay, you're still above, but, they weren't strong enough to go forward with that with a regulatory approval. So I think if someone did that study, I think I would be surprised again if, it was not usable. But again, we have to do the study. Okay.
Listen, guys, I think we're probably nearly, maybe a very quick last question from Chen Xiong. Just why is HIV prevalence going up or incidence going up? We've seen that in Australia since 2000. What's putting your behavioural hat on? What's the explanation? Do you have one?
Did you mean HIV incidents or did you mean syphilis incidents?
No, syphilis incidents, sorry.
Okay, yeah. So I think we're seeing that as well. I think there's a couple of reasons. Definitely, on one hand, we could be victims of our own success. And if you've got, more awareness about STIs, more people are getting tested, for example. Right. But I think what we are seeing with some of our PrEP programs as well is that there could be some aspect of behavioral change and sexual behavioral change as well. And I think one part of it is that increased perhaps condomless sex acts are happening in the community. And at least in our part of the world, in Southeast Asia, we also have seen an increased incidence of STIs and bacterial STIs in people who use drugs, for example, especially when we think about things like chemsex. So I think it's a multifaceted issue and something that really needs to be looked at from the behavioral lens, like you said. Thank you.
Okay. All right, look, we're nearly out of time. The Thai people apparently will cut us if we're not absolutely, it'll just go blank. So with the last 20 seconds, thank you very much, both of you, for excellent presentations and a good discussion. It's been a pleasure. I've learned a lot, and I hope people in the audience have too. I've asked most of the questions I think that came from the audience, so that's great. And well, good evening from Australia. And I hope you enjoy the rest of your evening. And thank you all for attending the AP Forum. And we hope to see you maybe in the next few days at the Asia Pacific meeting on AIDS and co-infections. So thank you very much and good evening.